Greetings, everyone. I'm Michael Keller from the Eastern U.S. Thank you so much to the organizers for the invitation to present our work today. I'm going to speak on the interim results of the ACES study, which is a study from the Pediatric Transplantation and Cell Therapy Consortium. Here first are my disclosures. I'll be speaking about an experimental therapy which is not FDA approved, which are virus-specific T-cell products. Viruses, as many of you know, remain a major problem in our immunocompromised patients with primary immunodeficiency and those undergoing bone marrow transplantation. And restoration of T-cell function is key to combating many viruses. Virus-specific T-cell immunotherapy has been used for several decades now as adjunctive therapy, but no studies have focused exclusively on pediatrics, nor evaluated their use in the pre-transplant period for our more profoundly immunocompromised patients. To address these questions, we undertook a phase 2 study to evaluate treatment of persistent viral infections with CMV, EBV, and/or adenovirus before or after bone marrow transplant, with the aims of determining whether third-party, partially HLA-matched VSTs are safe, with a focus on graft-versus-host disease and other infusional toxicities such as CRS, and whether they're effective against these three viruses. So VSTs were produced from healthy donors via rapid ex vivo expansion using peptide libraries against these three viruses, as shown in the lower left. And then patients who failed to improve with at least 14 days of standard antiviral therapy or who have treatment-limiting toxicities from antivirals were eligible to receive these cells on protocol and received a dose of 20 million cells per meter squared with 3 additional optional doses beginning 28 days thereafter. So to date, 37 patients have been treated on this trial, and they're roughly split equally between malignancy and primary immunodeficiency with various types as shown here on the lower left. 33 patients were treated post-hematopoietic stem cell transplant and 4 treated pre-transplant for SCID or related disease. Patients received 1 to 3 infusions to treat CMV in 14, adenovirus in 18, CMV and adenovirus in 2, and EBV in 2 patients. Overall response rates were 75% at 1 month, and we defined responses as a sustained minimum 1 log reduction in viral loads with a median response time of 21 days and a range of 5 to 59. So as shown on the lower left, responses were obtained in 8 of 11 patients with CMV, 16 of 21 with adenovirus, and 2 of 2 with EBV. Overall response to date is 68%. With most mortality occurring in the first month post-transplant, primarily due to progressive viral disease. The majority of our responders, however, remain long-term survivors. There was no de novo graft-versus-host disease. 2 patients experienced graft rejection post-infusion, in one case which was related to a subsequent liver transplant for VOD. Overall engraftment of the infused virus T cells could be detected in 17 of 21 evaluated patients to date. One of the methods we use for tracking the infused VSTs is by their discordant HLA proteins, since they are partially HLA matched. So in the case that I'm showing you here, VSTs expressed HLA-A02, as shown on the bottom row, whereas the recipient and the BMT donor on the top did not. Following stimulation of peripheral blood cells with adenoviral peptides at multiple time points, at 2 weeks, 4 weeks, and 3 months post-infusion, you can see that the A02 expressing cells were the predominant responders to those adenoviral peptides, suggesting that these VSTs are engrafting for several months after infusion. So overall, VSTs have been a helpful adjunctive therapy with a reasonable safety profile in our immunocompromised patients before or after transplant. Additional study is definitely needed in the pre-transplant period, as we've only treated 4 patients in that time realm. HLA restriction confirmation does seem to be very important to maximize response rates, and I welcome everyone to view our poster to see this data. I'd like to thank our many collaborators in the study, as well as NIH, California Institute of Regenerative Medicine, and Jeffrey Meldell Foundation for their support of this work.
Thank you very much, Michael. Very interesting presentation. I'm sorry I missed the start of the session, but I want to welcome everyone. If you have questions, please write your question in the Q&A section, and Arjan and myself will summarize the question for the presenters. if there is no question, maybe I will start. What is the delay between the infection and the re-injection of the CTL?
Our typical responses occur usually within the first 4 weeks if they're going to respond. But we definitely do often see a delay. Most patients really, and that seemingly is because they have to expand in vivo. So it's relatively rare for us to see an immediate drop in that first week. It has happened in rare cases. Forgive me if that's not what you're getting at.
Were there infection or disease related situation? I mean, whether just CMV or EBV reactivation, or did you have symptoms related to these infections?
Oh, sorry. Yes. So these patients were treated mainly. They were treated either due to viremia or to attributable viral symptoms. So it was, most of the patients treated had some symptoms. There were a small number that were treated purely for viremia, but we had some that were somewhere in the ICU due to pneumonitis. So some of them were actually, quite a few of them were quite sick.
Okay. And for the 3 or 4 SCID patients that you treated before transplantation, were they the same donors than the bone marrow transplantation for the CTL, or?
No, these are all third party. So all of them, none of them were derived from the same as the bone marrow transplant. These are all banked T cells from healthy donors previously produced and then used as off-the-shelf therapy so that we can immediately use them and get them to the site and use them. So all of them were different than the BMT donor.
Okay, thank you. I think we need to move on probably to the next presentation.
Yes, I'd like to introduce Reem Elfeky from London, United Kingdom, and she will present her experience in the long-term follow-up of transplanted SCID patients. Reem, please feel free to present your presentation.
Yeah, thank you for giving me the honor to present the late effect of post-transplant for patients with severe combined immune deficiency. This is work that I've done in Great Ormond Street Hospital when I was working there. I don't have any conflict of interest to disclose. So between 2005-2015, we had 106 patients receiving 117 transplants for SCID, and as you can see, most of the patients were actually transplanted after the age of 3.5 months. We have more B-negative SCID. In terms of the transplant characteristics, bone marrow with the main stem cell source, we had 38 matched sibling donor and 40 haplotransplant, and 36 of the patients didn't receive unconditioned transplant. So in terms of result, we can see 10-year overall survival of 80%. We have late death reported in 5 patients. However, if you look at the event-free survival, it was actually very poor, 48%. And I mean by events, death or a need for a second intervention, which was in 11% of the patients. Chronic GVHD seen in 21% of the patients, autoimmunity 17%, malignant transformation in 2 patients, and lung sequelae in 10%. What I would like to highlight here is that in 14% of the patients, there were late events recorded after 18 months of transplant. And looking further into this, so among these patients, we had 33% went for a DLI or a second intervention after 2 years of transplant, and one of these patients developed EBV-BTLD at 8 years post-transplant as another event. 2 of the patients had late chronic GVHD, and 8 patients had late onset autoimmunity with variety of autoimmune disease, IBD, nephrotic syndrome, myositis, hematological diseases, and autoimmune thyroiditis at the median of 73 months post-transplant. Only 1 of them had pre-transplant autoimmunity, 2 had Omenn syndrome. Most of them had unconditioned graft and low CD4 count recovery at 6 months, and 4 had mixed chimers. Looking at the factors that affect the event-free survival, it's very clear here that the age of transplant and diagnosis, B- or B-negative, intensity of conditioning, and the type of the graft did not affect 10-year event-free survival. Taking a step back and looking at the pre-morbidity, I looked at active infection at the time of the transplant, and I can see there is a drop, but it's not of significance. However, looking at the CMV, so having CMV before the transplant, CMV viremia or disease, or having active CMV during the time of the transplant, have significantly dropped the event-free survival. 6 months CD4 counts less than 300 or more than 300 did not affect the 10-year overall survival or 10-year event-free survival. And at the last follow-up, we had 85% of the patients had CD4 counts above 300, 80% above 500, and 76% were immunoglobulin independent. And again, 6 months CD4 count above 300 or having presence of myeloid chimerism did not influence getting off immunoglobulin. However, I noted that CD4 counts at last follow-up above 500 was associated with getting rid of immunoglobulin therapy. So as a conclusion, in this cohort of patients, we had the 10-year overall survival of 80%, however, with poor event-free survival of 48%. 2 leg complications were recorded among 14% of SCID patients after transplant. 3 pre-transplant CMV infection and active CMV during transplant influenced 10-year event-free survival, and this will be important as we are proceeding with the newborn screening. 6 months CD4 counts above 300 did not influence 10-year event-free survival. Number 5, which is very important, I think regular surveillance is mandatory after transplant for us to know the effect of our transplant techniques and try to see how we can improve long-term outcomes. And thank you.
Thank you so much, Reem, for this very clear and interesting presentation. Just to let you know that this is a large e-poster session because we have close to 70 people around your presentation, so there must be questions from the audience. But before I see the first question dropping in, what is your explanation for the CMV effect? Because I can imagine that, let's say, 1 year's survival is very much influenced by CMV infection at transplant. But what is your interpretation of the impact on long-term follow-up? Or is it determined by the early follow-up?
So I have looked into this more. So actually, in the patients who had the CMV infection or pre-transplant or during transplant, they are the patients who had chronic GVHD. So I think this is the link because I looked at autoimmunity, I looked at late deaths and the other complications. Only chronic GVHD is the thing that comes up very much. And this is, CMV is known to infect the thymus and affect the immune recovery. So it might be, this is why these patients have more problems.
Yeah. And if you look, let's say, at the deaths that you think are related to CMV or that cannot be
the early deaths, some of them were related to CMV infection. However, the late deaths were actually chronic GVHD and bronchiolitis after a second intervention. So it's not related to CMV at all.
Yeah. And I don't see any
questions about impact of chimerism on event-free survival from Mary's letter. Maybe Rem, if you have an answer.
I looked at chimerism and I did not see...
Mary is asking if the chimerism affected the...
No, so the chimerism did not affect the event-free survival. So all the patients have high T-cell engraftment, about 50%. But if I'm talking about myeloid engraftment, so absent myeloid engraftment, less than 5%, did not influence the event-free survival.
Okay. And did you look to the impact of naive CD4 T cells, for example, on event-free survival and survival?
No, I only looked at the CD4 counts at 6 months, but I did not look at naive yet.
Okay, great. Okay. I think we need probably to move on. And now we'll give the screen to Thomas Fox, who will talk about the outcome of transplantation in young adults and adolescents for PIDs.
Great, thank you very much. Yeah, so my name's Tom Fox. I'm from University College London, and I'm pleased to present to you today our poster entitled Excellent Outcomes for Adolescents, Young Adults and Adults Following Allogeneic Stem Cell Transplantation for Primary Immunodeficiencies. And this ties in well with Emma Morris and Bodo Grimbacher's debate earlier and Morgane Cheminant's presentation where she compared adults who'd been transplanted with those who aren't transplanted. And we hope this data will encourage you and demonstrate that age should not be a barrier for transplant for patients with primary immunodeficiencies. So I don't have anything to declare. So the background to this is as you'll all be aware, is that retrospective data in many disease groups has demonstrated that early transplant is preferred where possible. But there's a growing cohort of patients who survive to adolescence and adulthood without a definitive treatment. And this could be due to the lack of severe manifestations of their PID in childhood, a delay in diagnosis, a later presentation, or social reasons to delay transplant, for example, due to their education or fertility considerations. So previously, people were generally reluctant to transplant older patients with primary immunodeficiencies, as these were thought to be really high-risk transplants. And several years ago, we published our cohort of 29 adults who'd undergone transplantation with reduced intensity conditioning and showed that RIC transplants were safe and effective for adults with primary immunodeficiencies. And our overall survival was in the region of 85%. So we would argue that adults with primary immunodeficiencies with severe manifestation of their PID should be referred for consideration of transplant. And thanks to the efforts of Emma Morris and Siobhan Burns, this actually changed the clinical commissioning for transplantation for adults for primary immunodeficiencies in the UK. So what this updated cohort adds, and the kind of two key messages we wanted to get across to you today, are firstly that outcomes for adults with reduced intensity conditioning are improving. So I'd like to draw your attention to figure 1 in the top right, which shows the cohort of patients, 47 patients who've been transplanted in the last 10 years, and they have an overall survival rate of 93%. So that's significantly better than our earlier transplants. And the other key message which we'd like to get across is that in carefully selected patients in expert centres with reduced intensity conditioning, age does not necessarily confer an inferior outcome to transplant. And that's shown in figure 2, where you can see that our adult patients, those aged over 18, have equivalent outcomes to our younger patients. So these patients which were transplanted, the vast majority of them have a good quality of life. Only 2 have chronic GVHD. We see a relatively high rate of mixed chimerism, so 43 of these patients, a stable mixed chimera. But despite this, most have resolution in disease phenotype. The 3 deaths in the post-2010 cohort, 1 was due to transplant-related complications and 2 died of disease-related complications. These were both chronic granulomatous disease patients, and I think this just highlights that whilst transplantation is safe in adulthood, we do have to consider when to transplant, and really as soon as patients have severe manifestations of PID, one could argue that we should transplant as soon as that's apparent, and particularly in diseases such as CGD, where we know that many patients have a relatively aggressive clinical course. So I hope that this data has convinced you further that allogeneic stem cell transplantation with reduced intensity conditioning is safe and effective in adolescents and adults with primary immunodeficiencies. And really, in our experience, in carefully selected patients, age really shouldn't be a barrier to referring patients for consideration of transplantation. So with that, I'd like to thank the adult primary immunodeficiency transplant team at UCL, and I'm happy to take any questions.
Benedict, you have to unmute yourself.
I was mute, sorry. Can you just tell us what you mean by careful selection of patient? how did you select the patient, and how many organ dysfunction did they have at the time of transplantation?
So I think the careful selection goes down to what Bodo and Emma were talking about before, in that the patients need to be discussed in an MDT. So in the UK, we have a national primary immunodeficiency transplant MDT, where patients are referred to and discussed, and that panel includes expert hematologists, immunologists who have an interest in adult PID patients. So patients obviously are considered based on their underlying disease, but also the comorbidities. So obviously, patients with many comorbidities that are related to the disease are higher risk transplant candidates. So it's really, I think each patient needs to be considered on an individual basis.
There is a question.
So what was the second part of your question?
So Tom, one of the questions that came up is, the cohort has a substantial number of CGD patients. And do you have evidence, or maybe recent evidence, that other PIDs and especially, let's say, CID or CVID-like patients have the same performance in your transplant program, or do they have different outcomes?
So we had 3 CVID patients in this cohort. I think CVID is a difficult one because I think, the historical outcomes which were reported by Claudia Ware were poor, although one would argue that paper, quite a number of patients had myeloablative conditioning. So I think for CVID, there's really, really need a kind of a clinical trial or something to assess the role of transplantation in CVID. I think in the other PIDs, it's, there's a stronger argument for transplantation, but I think CVID is particularly difficult.
There are a few questions that appear on the Q&A regarding the type of reduced intensity conditioning that you used. Can you explain?
So the majority of the patients had FMC conditioning, so fludarabine, melphalan, and alemtuzumab.
And GVHD prophylaxis that you give to the patient, is it ATG related or post-POST-HAE?
Cyclosporin in the majority.
And upfront
and serotherapy, yeah.
Okay. And what was the average age of the adult in your series of patients?
So the age range was 18 to 50. I think from memory, the average age was 24. So the majority are younger adults, but there were some older adults in the cohort.
Okay.
I think because of time, we have to move over to the next presentation. Thanks so much, Tom. And to the audience, thanks for putting in all these questions. So we appreciate all the questions. So the next presentation will be given by Maddalena Migliavacca from Milano, Italy, presenting on behalf of the Raffaella team the experience with gene therapy for ADA-SCID. Sorry.
Okay, good morning, everybody. I would like to show you my experience, our experience with the first approved gene therapy for ADA-SCID. Sorry, okay. Okay, this is my disclosure due to present and past collaboration. As you can see, due to the algorithm that was published in 2019, all the patient diagnosis with the ADA-SCID can be stabilized with an enzyme replacement therapy. And after that, it's important to move this patient to a definitive treatment that can be a matched sibling donor transplant, if available, or gene therapy. In case of unsuccess of one of those 2 treatments, of course, the patient can restart enzyme replacement therapy, and we can consider an alternative donor that can be a match-related donor or an haplotransplant. In 2016, in EU, Strimvelis was approved as a gene therapy treatment for ADA-SCID in EU. And between 2017 and 2019, we treated 12 patients, 8 female and 4 male. We treated also 2 additional patients with immobilized product due to the inability to obtain a sufficient number of CD34 positive cells from bone marrow. And as you can see, as of March 2020, all the patients are alive with a median follow-up of 1.5 years, and the intervention-free survival that was defined as the requirement for a long-term PEG-ADA or hematopoietic stem cell transplantation is 91.6%. In fact, only 1 patient underwent 2 multiple haploidentical transplantation after gene therapy. As you can see in this panel, in the filled green box plot, you can see the level of correction of this patient. The transduced cells appear at 3-6 months post-GT. In particular, the VUCN on the CD3 show really an increase during the time and a persistence of this transduced T cell through the last follow-up. In the unfilled green box plot, you can see the immune reconstitution. The lymphocytes count increased at 6 months post-gene therapy in almost all the patients and reached the normal level in some of these patients at 1.5 years after gene therapy. Importantly, as you can see in the panel on the right, all the patients achieved an adequate systemic detoxification with a level of DXP that are below 100 nanomole ml. That is the threshold that was defined in successfully allogenic transplanted patient. So, in conclusion, we presented the data follow-up of our 12 first patient treated with Strimvelis. The overall survival was 100. The intervention-free survival was 91.7%. The engraftment of the corrected cells, the immunological reconstitution, the detoxification were superimposable to the data reported in literature. At 1 year of follow-up, 5 out of 7 patients stopped EVIG. All the patients achieved an adequate detoxification and displayed normal and improved growth. And the efficacy and safety of this data are in line with the product information. Of course, we are continuing to monitor our patient with a long-term prospective registry study. As you can see, a lot of persons are involved in this project, so I would like to thank you everyone, in particular Professor Alessandra Aiuti and Maria Piescicalese, all the physicians, all the patients, and all of you for your attention.
Thank you so much, Madalena, for this wonderful presentation. There will be questions in the Q&A chat. Let me check.
May I ask one question? What was the average age of this patient at the time of transplant of gene therapy?
Okay, so I have not here the precise results, but they are mostly young people, so nearly, I think, 2 years of median age can be the one that...
So you didn't treat older patient?
Sorry?
You didn't treat older patient in these 12 patients? I mean, patients that were on enzymes for quite a long time and then went to gene therapy after a while.
The cohort is mostly on younger patients, but we treated also, I think, twice that are nearly 10 years old. So they are like a late onset form. So they start PEG-ADA not so much before gene therapy, but yes, they are older patients.
Okay. And for the immune reconstitution, we didn't see very well, but the level seems to be lower than the normal range for CD4 and CD3. Were you happy with the quality of the immune reconstitution?
Okay, yes, we are, because the patient really, almost all the patient restarts a normal life. They doesn't has so many infection. They stops AVIG. So, and I think that there is a gradual and constant trend to increase this number. So we really think that the data will be similar to our protocol that we studied before.
Madalena, could you Can you elaborate a little bit more on the subgroup of patients that is still IVIG dependent at 1 year? If I remember well, there were 7 evaluable patients and 5 were off IVIG, meaning that 2 still were dependent and probably had, let's say, suboptimal B cell function. Can you tell us a little bit more about these patients?
Yes.
Do they have certain characteristics?
At 1 year of follow-up, only 7 patients reached this follow-up. 2 of them, yes, were still on EVIG. We continue to monitor the engraftment cells, and we saw that there is a little increase over time. So we are not worried for this patient, but surely they need to continue the EVIG because they are not in a good number. The lymphocytes B also show are in accordance with the EVIG level. So we don't think that there is anything.
And could you relate, let's say, the outcome, especially the immune reconstitution performance? Could you relate this to the quality of the infused gene therapy product? For example, the number of cells or the number of the transduction.
Okay. No, we monitor also that characteristic, but we don't find statistically difference in the number of cells infused. The only thing that we can say is that these 2 patients are the older one. So maybe they are the one with, of course, a different characteristic of the other patient. We really think that, of course, this one is the better for this kind of patient. So if we treated it before, they also the outcome is really well.
Don't think there are any additional questions in the Q&A chat room.
Okay, so I'm happy to introduce Annick, who will talk about the management of GLID in CVID disorders.
Yes, thank you. Good evening. I would like to share with you some results of the online survey we conducted related to the management of granulomatous lymphocytic interstitial lung disease, or GLILD, in CVID disorders. And I present these data on behalf of the GLILD Net, which is a clinical research collaboration founded by the European Respiratory Society and supported by ESID. I have nothing to disclose. Many of you are probably aware that CVID can be complicated by severe disease manifestations, and GLILD is one of them. Since there's no international consensus available, let alone randomized controlled clinical trials, the GLILD Net conducted an online questionnaire among clinicians caring for GLILD patients with questions related to diagnosis, follow-up, and treatment. And despite the COVID-19 pandemic, over 150 clinicians from all over the world managed to fill out the survey. As time is restricted, I will now briefly discuss the findings on therapy-related questions. Regarding immunosuppressive therapy, about 2/3 of the respondents used steroid monotherapy for remission induction in the doses of usually 0.5 to 1 milligram per kilogram body weight. But this may vary, and pediatricians often use more than 1 milligram per kilogram. Steroid monotherapy is also used as maintenance therapy by 47% of the respondents. But we were mostly curious to find out which steroid-sparing agents were prescribed and asked respondents to rank their most commonly described conventional or biological DMARDs, as is depicted on the left. Here we show the top 3. The graph clearly illustrates that the heterogeneity in answers, but azathioprine, rituximab, and MMF are most commonly employed. Bear in mind, though, that the patient numbers are really low. Most respondents only treat 1 to 5 patients with these drugs. Moreover, the choice of ranking is not exclusively based on the clinical effectiveness as perceived by the respondents, because if we plot the most frequently described DMARDs, or a combination thereof, we see that the number 1, azathioprine, is not regarded the most effective one. The largest proportion depicted in orange feels that only some patients respond, while rituximab, particularly with MMF combined, is perceived to be more effective. But other factors influence drug choice as well, such as side effects. And for rituximab in particular, people mention the cost and the availability as a limitation. So therefore, the graph on the right of which drug one would recommend looks slightly different than the ranking on the previous slide. So here you can see that MMF and rituximab are a combination where most often recommended. And lastly, we asked whether respondents applied antimicrobial prophylaxis against pneumocystis Elfeky pneumonia, and also received very mixed responses, both within and between the different specialties. So the other adult specialties were mostly internists and infectious disease specialists, and they were most willing to apply antimicrobial prophylaxis, while pediatricians were more reluctant to do so. So to sum up, there's a clear lack of consensus on the therapy of GL-ILD, and we need clinical studies aiming to gather some evidence related to the management of GL-ILD. And with this aim, the eGL-ILD net was established last year by John Hurst and Klaus Warnert, with the aim to facilitate international collaboration. And this survey was one of the initial projects, and another survey prioritizing unanswered research questions was just finished. So this should facilitate further GL-ILD research. So thank you for your attention. And if you're interested, you can follow us on Twitter at eGL-ILDnet. And I'm happy to take on some questions.
Thank you very much for this nice presentation. You very nicely show the need for further studies in this difficult situation that you face more frequently in adults than we do in children. I don't know if there are questions in the Q&A. Maybe one question about the place of biologic agents like anakinra in this clinico-pathologic situation.
Anakinra, it's mostly anti-inflammatory. That's actually not often used in this disease. We didn't put it in the list. I don't know any case reports or anything that use it, although it may help because there are a lot of cells involved. But therapy is mostly directed against more the adaptive immunity, T and B cells. So most people use steroids for remission induction, and then one of the DMARDs I mentioned in the list, and there were some exceptions. So there was also some cyclosporin A, but anti-IL-1 therapy was not used by any of the respondents.
Annick, do you know whether there is any experience with sirolimus in the use of treatment GLILD?
There were some respondents who mentioned they had some individual cases of sirolimus use, and at our hospital we had one too. So that's mostly mTOR inhibitor. It was successful. It's only NS1, so really anecdotal evidence, but it's used, and tapering of prednisone was easier when the sirolimus was started.
And if you would have a patient in front of you tomorrow, what would you advise?
Yeah, that really depends on his or her condition and if they have symptoms. First I would like to exclude an infection, so the diagnosis has to be established first, and then you have to take in mind the general condition of the patient and if there's deterioration on the scan, and it really depends on the severity of the disease. So probably induction with steroid monotherapy if I think there's treatment needed, and then the best results are shown for rituximab combined with azathioprine or MMF, I think. But I would discuss it with my colleagues and have a look at the specific situation, because the evidence is really small.
Okay. I don't see any questions in the Q&A. Are there any other questions from the group? If not, and the group is large, I can tell you, so you are very popular with your presentations, because we have more than 100 participants, which is not an e-poster session anymore, but a full plenary session, to be honest. So having said that, I think we can move to the next presentation by Maria Fassauer from Germany, and she will share data on facilitated immunoglobulin administration in a registry setting. Maria, the floor is yours.
Thanks for the very nice introduction. And I'm very pleased to be able to present our preliminary data on behalf of my co-authors and myself, giving you the interim analysis of the facilitated immunoglobulin administration registry and outcome study, Figaro, assessing utilization and of facilitated subcutaneous immunoglobulin, short ADSCID, according to patient age group. Here are my disclosures. So the background of the study is to assess ADSCID use in real-world setting. ADSCID is a dual vial.
Not you, Maria. Am I the only one that doesn't see your screen, or?
No, I don't see neither.
Oh.
You have to share your screen.
Okay. I did as I was supposed to, so I try again. Excuse me. So can you see it now?
I can't.
Can anybody see it?
Gaines, please assist us.
No.
I did as I was supposed to. I'm sorry, it's not working the way.
Something in the cloud.
So can you see it now?
I can't.
No.
Okay, it was working on the rehearsals. Should I just so we're not losing time?
Maybe we can shift to the next presentation, and then you can have your time to reschedule. Sorry for this interruption.
Sorry.
The next presentation will be presented by Kubra and is related to the treatment of CGD-associated colitis in a patient with mixed chimerism after transplantation using ustekinumab that block IL-23.
Thank you. I'm Dr. Kubra Baskın from Ankara University School of Medicine, Department of Pediatric Immunology Allergy. Many thanks to Organization Committee for this great chance of online congress. I declare that I have nothing to disclose. All we know, CGD is a rare primary immune deficiency caused by the Fexton respiratory burst of phagocytes. Patients are susceptible to severe life-threatening bacterial and fungal infection and granuloma formation. Also, colitis mimicking ulcerative colitis is seen in nearly half of patients. In CGD, chronic inflammation leads to excessive IL-23 production by antigen-presenting cells and facilitates differentiation of inflammatory Th17 cells. Ustekinumab is a targeted therapy for this. Ustekinumab is first approved in 2009 for psoriasis and psoriatic arthritis and used as biologic treatment for moderate to severe Crohn's disease since 2016. It is a monoclonal antibody to shared P40 subunits of IL-12 and IL-23 and antagonizes binding these interleukins to their receptors and blocks Th1 and Th17 pathways. Let's see our case. A 6-year-old boy diagnosed with CGD after fungal lung abscess was referred to our clinic for hematopoietic stem cell transplantation. We transplanted him from a full match unrelated donor with a conditioning regimen consisted of low-dose busulfan, fludarabine, and alemtuzumab. He was well mixed myeloid chimerism cis transplant first month, but unfortunately, 44 months after transplantation, we hospitalized him because of new onset bloody diarrhea, abdominal pain, and fever. On admission, laboratory tests revealed mild anemia and elevated CRP levels with normal biochemistry tests. We couldn't find a specific microorganism or microbiological examination, so decided to perform colonoscopy. Colonoscopy revealed macroscopically diffuse edema and hyperemia of rectum and hyperemic granulomatous lesions in descending colon, and microscopically cryptitis, crypt abscess, and granuloma formation. Intestinal GvHD findings weren't detected. At the same time, there was a reduction in mean fluorescence intensity in the heterodomain assay too. We decided to start mesalamine treatment, but couldn't control disease. There was a flare-up in colitis 1 month later the treatment, and persistent reduction in mean fluorescence intensity in the heterodomain assay. So we added hydrocortisone suppository and exclusive enteral nutrition to treatment, but achieved little success. Then we decided to use ustekinumab for treatment. You can see the treatment schedule here. At the beginning, we started twice monthly for 4 doses, 2 mg per kilograms, and then later monthly for 2 doses. 2 monthly for a month. Patients received up to now 7 doses, and even after first dose, we were able to control colitis. He put on weight and is well without any complaint for last 7 months. Control colonoscopy performance revealed both microscopic and microscopic healing. In conclusion, we think that mixed chimerism after bone marrow transplantation in patients with CGD is not enough to control disease. Colitis associated with CGD is very severe, and ustekinumab is found very effective, but further studies are warranted. Thank you for your attention.
Thank you for this nice case report. Are there questions in the Q&A? Do you have the chimerism level at the time of the colitis and the level of the DHR?
Yes, we had. There was a little reduction in chimerism too.
What do you mean by mild decrease? Do you have a number or percentage of chimerism?
It was nearly 60%.
It's quite unusual to have severe colitis with 60% chimerism in CGD. And what was the level of the DHR, the percentage?
Sorry, I couldn't understand the question.
What was the percentage of DHR at the time of colitis?
60%.
Okay, and the chimerism 60%.
Yes.
Are they?
So Kubra, with respect to, I mean, it's interesting effect of this intervention. What is the further plan with this patient? Will you keep this patient on maintenance therapy with this drug, or is it a way to get the patient in a better condition and do something else as a next step?
It's a difficult question to answer. There isn't a consensus about duration of the treatment of ustekinumab, even in better known disease such as Crohn's disease or psoriasis. We decided to use ustekinumab with mesalamine for a year, and then the clinical course will help us to decide what to do.
Okay.
We will use for a year this drug.
Okay. There was a question from David Lowe on the potential risks of mycobacterial infections and the use of ustekinumab. Can you share your ideas on this, or maybe your experience?
Yes. It is the first time that we use this drug, but there are some studies about safety of this in Crohn's disease and psoriasis. 3 years and 5 years safety is reported, and there aren't any increased risk of adverse events or serious adverse events or increased infections, malignancy, or major cardiovascular events. So we think that it is as it is a targeted therapy, it is suitable and safe.
Okay, just checking whether there are any other burning questions.
One more question about the chimerism on subpopulation like T cells and polynuclear. Have you done some chimerism in this subpopulation?
Yes, we had. T cell chimerism is 35%. Unbound chimerism was nearly 50%.
Okay. Shall we move on?
I think we got just to check. Maria, is your presentation already available, or should we move to the next one first?
I sent it to a technician. I don't know if they got it by now. So maybe you move on to the next person and just take me to the last.
Okay, then we first go to Alessandra Mortellaro again from Milano, and she will share some interesting new data on lentiviral mediated gene therapy in ADA2 deficiency.
Oh, shit.
Alessandra, the floor is yours.
Yes. So, good evening, everyone. I have nothing to disclose. So, clinical manifestation of DADA2 include vasculitis, ischemic stroke, intracranial hemorrhages, immunodeficiency, and hematologic abnormalities. There is a high medical need as a significant proportion of undiagnosed or untreated patients die, and there are currently no targeted therapies. We believe that hematopoietic stem progenitor cell gene therapy using a lentiviral vector may represent a therapeutic option for patients who cannot be considered for allogenic bone marrow transplantation. Therefore, we generated a lentiviral vector in which the expression of the human ADA was driven by the ubiquitous human glycerophosphogylutamate kinase promoter, which allows stable expression of therapeutic proteins and has been shown in previous studies a positive risk-benefit profile in different clinical trials. Therefore, human CD34, isolated from bone marrow of 3 independent donors, have been transduced with the ADA2 or GFP lentiviral vector at increasing concentrations. Most of the granulocyte macrophage colonies and erythroid burst units were positive for ADA2 lentiviral vector, reaching clinical relevant levels. At each vector dose, ADA2 lentiviral transduction of CD34 did not affect the growth of CFU-GM or BFUE colonies, indicating that the clonogenic potential of CD34 positive cells remains intact upon ADA2 delivery, even at a high vector concentration. Upon transduction at increasing vector concentration, we observe a dose-dependent increment in the ADA2 expression at both mRNA and protein levels. And importantly, secreted ADA2 possesses the proper enzymatic activity as revealed by its ability to convert adenosine into inosine. Next, we investigated the ability of our ADA2 encoding lentiviral vector to restore ADA2 expression and activity in bone marrow-derived CD34 positive of 2 adult patients with DADA2. We found that LV-mediated ADA2 delivery reestablished intracellular expression in patients' CD34 positive cells. Vector-derived ADA2 was also secreted by transduced cells in a dose-dependent manner, and the secreted ADA2 showed a functional enzymatic activity. The ADA2 is associated with an increase in one pro-inflammatory macrophage profile. From a prospective clinical application, we studied We studied whether ADA2 transfer in macrophages could correct this hyperinflammatory phenotype. ADA2 protein was nearly absent in untreated macrophages from all the patients, indicating that patients' mutations are associated with a complete loss of ADA2. Macrophage transduction with ADA2 lentiviral vector established the extracellular ADA2 activity, and monocytes-derived macrophages from 6 patients with ADA2 were transduced with the lentiviral vector and polarized into M1 macrophages. We found that uncorrected patient macrophages release IL-6 and TNF at high level in response to inflammatory stimuli, but ADA2 correction led to normalization of cytokine secretion in all the patients. In conclusion, the data presented show the therapeutic value of our ADA2 lentiviral platform and further support preclinical studies for its clinical development. Thank you for your attention.
Thank you so much, Alessandra, for this very interesting presentation. If I may start with a question on the concept of gene therapy for this particular disease, which is a complex disease. What is your perception on the level of correction that you would need to treat ADA2 deficiency because of the required levels of enzyme, etc.?
I mean, we know that ideally we need to reach at least physiological levels. There are carriers carrying one single loss of function mutation that show some signs of disease, although can be in milder form or at late onset. So ideally, I think we need to reach at least 70-75% of the physiological levels. We don't know at the moment exactly if it's important the intracellular enzymatic activity or the extracellular, the systemic levels that are commonly used to diagnose DADA2.
And in that context, could you draw kind of a similarity with, let's say, some more, let's say, traditional inherited metabolic diseases where you would aim for a transduction strategy where you would have, let's say, relative overexpression on a per cell basis?
I mean, if we compare with the other ADA1 enzyme, which leads to ADA-SCID, what we can say that this disease we think is not exhibiting any survival advantage, selective advantage of transduced cells. So, and if we compare with other metabolic disorder like lysosomal storage disorder, in which high levels of enzyme are required, I think ADA2 is quite different and peculiar. I don't think we need to reach such a high level as much as in these disorders. But of course, the lack, we need to do more in vitro studies to quantify and to correlate correction of the disease, enzymatic activity and protein expression.
And again, from a biological perspective, do you think that if you perform gene therapy, you most likely end up with kind of a carrier status, given the complexity of this disease? Do you think that could influence the correction of the disease manifestations when you have, for example, 40-50% corrected cells, but also 40-45%, 40-50%, let's say, non-corrected cells? Would these cells still be able to cause problems?
I mean, your question is really important. We don't have any data at the moment, and it's difficult to answer because there is no source to study how much correction is needed to really correct the manifestation of DADA2. So this limitation, less to assume that at least 50 or 75, 80% correction would be enough to achieve an efficacious treatment. But we don't have data, it's just a guess.
Well, thank you so much. I think we have to move over to Benedict.
Okay, I think, Maria, are you ready for your presentation? Is it working?
I hope it does now. Can everybody see it now? Okay, so I'm very sorry that happened. So I'm going to start at the beginning again. So I'm introduced, well, now I'm working in Germany, in Leipzig, and I'm seeing patients being children and adults with primary immunodeficiencies there. And I'm very pleased that it's now working to present our data of the FIGARO study. On the second slide are my disclosures. Next, please. And the facilitated immunoglobulin study is to assess this fairly new drug in use of real-world setting. ESID-2020 is a dual vial that contains a 10% IgG formulation and recombinant human hyaluronidase. Is approved in Europe for treatment for patients with primary and secondary immunodeficiency. And the objective was to evaluate the ESID usage and outcome in different age groups in FIGARO study. So here you can see the methods. FIGARO is an ongoing European multi-center prospective observational study. And patients who received at least one ESID infusion, either for PID or secondary immunodeficiency, are included and are planned to be followed up for up to 3 years. An interim analysis, the cutoff date was August 2nd of this year, is conducted, and patients' characteristics, infusion parameters, and tolerability analyzed by the 3 age subgroups as being pediatric patients younger than 18 years, adult patients between the age of 18 and 64 years, and older adult patients being older than 65 years. Next. Here are our results. First, I want to show you the patients and administration parameters. The data are available for 154 patients, being 13 pediatric patients, 120 adults, and 21 older adults. And most of pediatric and adult patients received facilitated subcutaneous therapy for PID, while most older adults received ESID for a secondary immunodeficiency disease. In each age group, the median monthly dose of ESID was 400 milligrams per kilogram body weight, and the patients predominantly received ESID every 3 to 4 weeks in all age subgroups. And down below here on the bottom, you can see on the left-hand side and on the center in these two figures that the infusion settings for the adults, which is the middle bar, are basically the adult patients do it at home and self-administer compared to children and older adults. And throughout all 3 subgroups, the patients only needed 1 infusion site, as seen on the right-hand side picture. So on the next slide, next please. I'm coming to the tolerability data. It was drug reactions that were reported at inclusion visit were mostly local infusion site reactions. That is in 2 pediatric patients, 22 adult patients, and in 1 older adult patient. And systemic adverse drug reactions were reported only in adults, that is in 12 adults and 1 older adult. So concluding, you can say that facilitated subcutaneous immunoglobulin provides flexibility in dosing and also in the administration settings across all age groups. And regardless of age, the majority of patients require only 1 infusion site, which is very good for the children. And they can receive the full dose, mainly using self-administration at home, scheduled every 3 to 4 weeks. And facilitated subcutaneous immunoglobulin was tolerated across all age subgroups. And if you need more information and need an interactive version of this poster, you can scan the QR code. And with this, I want to conclude And I want to thank you all for your patience with me and with the technical problems I had. And I want to thank you for your time and attention, and I am glad to take questions. Thanks.
Thank you very much, Maria. I don't know if there are questions in the Q&R. Otherwise, you don't have any data about immunoglobulin levels and success of the treatment. I guess it will be analyzed further.
The IgG levels actually are on the poster. So if you want to see them later, yeah, we had
a few words.
Which ones we put on this presentation? Yeah. So actually there are more data on the poster so if you want to see those. So but the levels are very good in all three subgroups. Okay. But as we sometimes see also in other studies, the patients with secondary immunodeficiency are having fairly lower levels of IgG compared to the ones with primary immunodeficiencies.
Mm-hmm. There are few children included in the study. Are you? Do you have in mind to increase the number of children in the future? Because the data in children are still quite low, I would say.
Yes, definitely. There is another study going on assessing facilitated subcutaneous therapy only in children. But for Figaro data, when we started including the product was not licensed for children as for such a long time, like it was for adults. So the labeling was earlier for adults than for children. So with this delay, we included less children in this specific study, but there is a planned study for assessment of facilitated immunoglobulin only in children that is just starting to go on at this moment.
Okay, great.
Anika, I think you would like to ask a question if I see it quite well in the chat. You can do it yourself.
Yes, thank you. Yeah, I was wondering if you look at BMI or how skinny the patients were, particularly in children, because we often see that they don't tolerate it as well because you need some cutaneous fat to inject in. Do you have any data on that?
Right. Exactly. Thanks for the question. Of course, we know this problem as well. And the BMI it can also be seen on the e-poster. So if you want to know the exact numbers, what our personal experience is, as I'm a pediatrician, using the hyaluronidase, you prepare the tissue to take this amount of volume. And as being a pediatrician, we are rather cautious, so we don't speed up the infusion that much. The youngest patient I ever used facilitated immunoglobulin subcutaneous on was 3 months, and that was working fairly well. So, yes.
Okay, thank you.
I think it will probably be time to conclude, Arden, because I think we are late.
Yeah, I think we have to conclude. Well, I think we have to thank everybody who joined the poster session. First of all, thanks to all the speakers. You did an excellent job, and you were stress resistant when things technically weren't optimal. So congrats for that. Many people around your poster, so I hope they can trace you if they have some additional questions that we couldn't address during this session. At the start, we already said in the inner circle group, it's time for pretzels and beer. I don't know what you are going to do, but I'm going to have my beer. So enjoy it as well. And now it's some time for relaxing. Thanks again, also on behalf of Benedict, and enjoy the rest of the meeting.
Yeah. Thank you very much to everyone, to the presenters, but also to the people that were in the room, and enjoy the evening. Bye.